Hello and welcome to my channel. My name is Maria and this is my very first lecture in the pharmacology section, and for today's topic I have chosen antihypertensive drugs. The reasons for this is because those are one of the most prescribed drugs, and hypertension is one of the most seen disease in medicine. So, as you can see, for today's lecture, I have prepared one short presentation, and I'm going to upload this presentation under the video in the section of description, and from there you can download it. So, on today's agenda are the following six topics. So the first one is we're going to start with shortly introduction. Afterwards, we're going to answer the most important question: how do we study pharmacology? After that, we're going to have a very quick revision of RAS system. And in the end, we're going to study and try to understand, learn, and memorize today the three group of drugs which are acting directly on the RAS system itself. So I just wanted shortly about introduction to say about myself. I'm a recent graduate of Medical University Sofia, and I have a deep interest in pharmacology as well as in genetics. So I hope through these videos I can help many students to understand way easier pharmacology, to not be scared of pharmacology, and I hope to wake up your curiosity about it. I know it can be it is one of the most difficult subjects, but for that to not be like that, I would like we to answer to this question. How do we study pharmacology actually? So, from my personal approach in third year, when I started to study pharmacology, I had a little bit difficulties in the beginning. But the reason behind this was that I have forgotten a very big part of pathophysiology. And I have forgotten pathophysiology because actually I have never understood properly physiology on the first place. So in the first place, I decided that I have to revise first of all physiology, let's say learn it from the very beginning, because in physiology we study how the healthy body is working properly and which are the mechanisms our system itself is balancing. And then when something will going to go wrong, for example, when some mechanism is going to fail or is going to be overstimulated, then we're going on our very second thing, which is pathophysiology. So pathophysiology is one more time a subject which is focused on the mechanism of the disease. What is the pathogenesis? How actually the disease occurred? What went wrong so this disease to exist? And the last thing is actually pharmacology. Because when we study pharmacology, we have to know the pharmacokinetics as well the pharmacodynamics of the drug. And now here comes the difficult part, is actually the mechanism of action of the drug. Why most students cannot understand them or memorize them? Because actually the mechanism of certain drug, especially of the drug of your choice for treating certain disease, it's exactly the same as the mechanism. It's actually the mechanism of the drug itself has to somehow improve the mechanism of the pathogenesis. So for our drug to work on something, we have to understand where and how did this pathogenesis happened. Which mechanism went wrong so this disease occurred. So these are my tips how we should study pharmacology. First, we have to revise physiology, afterwards pathophysiology, and in the end we have pharmacology. For this reason, today's topic, as I said, are antihypertensive drugs, and I will use these tips, and through today's lectures, I hope you can see in which way I meant you to revise physiology, pathophysiology, and in the end, the drugs themselves. So, as I have said, antihypertensive drugs are deeply correlated with RAS system. Now, from physiological point of view, what is RAS system? RAS system is actually renin-angiotensin-aldosterone system. And why is it actually connected with blood pressure? Because this is the system which is one hormonal pathway which directly regulates the blood pressure. But besides directly regulating the blood pressure, it also regulates the fluid balance and the electrolytes homeostasis. So, from physiological point of view, we have to understand that RAS system is connected with blood pressure because actually it regulates the blood pressure. Now, we have to think how actually the RAS system is regulating the blood pressure. For this reason, I have chosen this picture from Wikipedia. As you can see, in this picture is represented the RAS system itself. And as I said, what is the question? How does the RAS system regulate the blood pressure? This is our main question, which we have to first understand. And after we have understood this part, we have understood how RAS system is connected with antihypertensive drugs. Now, from this picture, we can see that a couple of organs are included. The first organ is kidney. After it, we have liver, lungs, and here down we have pituitary gland, and as well we have blood vessels. So, let me start from the very beginning. So, from the very beginning, we can see that renin is the first hormone which is going to be released from the kidney. While on the other hand, angiotensinogen is released by the liver. And what is going to happen once renin is going to be released from the kidneys? It is going to convert angiotensinogen into angiotensin 1. Afterwards, what is happening? By the help of the enzyme angiotensin converting enzyme, angiotensin 1 is going to be converted into angiotensin 2. But wait a minute. How did we actually get this angiotensin converting enzyme? Important is to remember that this is formed by the endothelial cells. This enzyme is made. This enzyme is made from the pulmonary and the renal endothelium. And our very last outcome is the angiotensin 2. Now, the big question was, how does this system actually regulates the blood pressure? So this is the pathway of the system. We have a release of one hormone which is converting another into angiotensin 1. And in the end, we have the fabulous angiotensin 2. Now, what is actually the angiotensin 2 doing? It is going to the pituitary gland and it is stimulating the pituitary gland to release antidiuretic hormone. Why? Because the antidiuretic hormone is going to go to our kidneys, more specifically on the collecting duct, stimulate, first of all, bind to the antidiuretic hormone receptor and stimulate the aquaporins. And now the question is, okay, but why do we need to stimulate aquaporins if we would like to regulate the blood pressure? Because when we are going to have low blood pressure, let's say, then what is going to happen? This means we can also have in the same moment a decreased volume, a circulating volume. This means what? We need to somehow increase the circulating volume. And how you're going to increase the circulating volume? The first way is if you're going to increase the reabsorption of water. So in this case, antidiuretic hormone is actually helping us to increase the circulating volume, which is respectively increase the blood pressure by reabsorption of water. Now, similar thing is happening here. Angiotensin 2 is going to go to the adrenal gland, specifically in the cortex, and this will stimulate release of aldosterone. Now, aldosterone is a new hormone. So until now we spoke about antidiuretic, now we have aldosterone. What is aldosterone doing here? So it is going to cause sodium reabsorption and potassium excretion. Now, again, probably you're wondering, why do I need sodium reabsorption or what do I need potassium excretion? Please remember, wherever sodium goes, water follows. This means as long as you have sodium reabsorption, you are going to have as well water retention. And in this way, you are going to again increase the circulating volume. And now we have something else what is left here. We have arteriolar vasoconstriction. What does it mean? This means that the arterioles, which are just, we have two afferent and efferent, one is on the entrance before the glomerulus and one is on the exit. If we are going to cause vasoconstriction or decrease of their diameter, this means they're going to have less diameter, but the amount of fluid which have to pass through them is the same. Or in other case, we have even a little bit increased it because we have water reabsorption. This means we're going to increase the vascular resistance. In this way, we're going to increase the blood pressure. So until now, we have found two ways how we can increase our blood pressure. By increasing the blood volume, or so-called circulating volume, and on the other hand, by causing increased systemic vascular resistance. Now, this is the physiological part of renin-angiotensin-aldosterone system. Until now, we have studied and understood how this system is going to increase our blood pressure. Now, we have to understand when does the system get activated. The first time when the system can get activated, I mean to say first time it's pretty wrong, but let's say one of the examples when the RAS system gets activated is when we will have decreased renal perfusion. When you can have a decreased renal perfusion? Mainly when we have hemorrhage, for example, any type of bleeding, trauma which can lead to bleeding, dehydration, vomiting, diarrhea, fever. These are things which can lead to overall decreased volume, circulating volume, which can lead to decreased renal perfusion. On the other hand, when we have decreased sodium levels, for example, can be as well when we have decreased sodium intake. And now, what happens when the renin-angiotensin system gets activated? What is the final result? The final result is increased blood pressure, increased systemic vascular resistance, and in the end, increased blood volume. So, I hope that by now we have understood what is RAS system, which are the elements of the RAS system, how does it physiologically increase the blood pressure by all of those mechanisms, when does it get activated, and what is the final result of the RAS system? Increased blood pressure. Now, let we think, before we continue to the next slide, let we think something else. What if our patient has high blood pressure and this system gets activated by mistake or unnecessary? What should we do? Of course, the only right answer is to stop this RAS system working. So there won't be additional factors which are going to lead to high blood pressure in our patient. How do we do that? We can do that in three ways. By using direct renin inhibitors, by using drugs which are going to inhibit the angiotensin converting enzyme, or drugs which are going to block the angiotensin 2 receptor. This is the receptor where angiotensin 2 is binding to. What will be the overall mechanism is that once we block the RAS system itself, we won't have water reabsorption. This means what? We won't increase the circulating volume, and we won't have vasoconstrictions. This means we won't increase the systemic vascular resistance, and even in some cases we can have a dilatation, slight dilatation of the efferent arteriole. So now we are having three groups of drugs. The first one is going to talk about the direct renin inhibitor. So here is the direct renin inhibitor. The drug name is called aliskiren. How does it work? What is the mechanism of action? It directly binds to the active site of renin. This means what? Renin cannot interact with angiotensinogen, thereby angiotensin 1 won't be formed. And if we don't have angiotensin 1, we won't have, as we said, vasoconstriction, we will have decreased blood pressure, we won't have aldosterone secretion, sodium and water reabsorption respectively going to be decreased. Then we don't have stimulation of the antidiuretic hormone, and we don't have increase of the blood volume. When this drug is actually contraindicated in case of pregnancy, allergies, angioedema, severe hyperkalemia, and bilateral renal stenosis. Why severe hyperkalemia? Just because we said here that what actually the aldosterone itself is doing, it's causing sodium reabsorption and potassium excretion. Potassium excretion means that the potassium is going to move from the cells into the urine, and it's going to be in our urine, and then it will be urinated. But in case we take aliskiren, what is going to happen? We're going to block all of this. This means that the sodium is going to stay in the urine, will not be reabsorbed, and potassium is going to stay in the cells. So if our patient is already having hyperkalemia, which means increased level of potassium in the blood, we don't want to increase the potassium furthermore with this medication. Our next group of medication is ACE inhibitors. This picture is actually from my favorite professor, Dr. Koleva, and she's my biggest motivation for studying so hard pharmacology, and I'm really grateful that she was my professor in my third year. So this is just like a small joke about this group of medications, and I hope this will help you remember their names. A couple of medications in these groups are enalapril, ramipril, lisinopril, and captopril. Now, first of all, when we study this group of drugs, what do we have to understand? Mechanism of action. What do? They block directly the angiotensin converting enzyme. This means what? We don't have conversion of angiotensin 1 into angiotensin 2. Now, here you have very interesting thing about pharmacokinetics. Two groups. We have prodrugs and drugs. So what are prodrugs? Prodrugs are actually drugs which have to go through our liver, get metabolized, and afterwards they are activated. Before that, they are in inactive form. While drugs are medications which are directly in active form once you have taken them. So prodrugs from this group are enalapril and ramipril, while drugs in their active form since the beginning are lisinopril and captopril. I would like to add, this is here a quick explanation why actually these drugs as well are thought to be nephroprotective drugs. Three things actually. The first thing is because they decrease the intraglomerular pressure. This means the pressure within the glomerulus. Why? Because they will decrease the peripheral, they can decrease the peripheral systemic resistance. Why? Because they're going to cause dilatation of the efferent arteriole of the glomerulus. Just 1 second. Nephron. just I wanted to show you this picture. The idea is that we have afferent artery from where our blood is coming from, then is getting filtrated within the glomerulus, and then is leaving through the efferent. And what are actually this medication doing? They are causing slight dilatation of the efferent. This means we don't have a very high pressure, which this blood, which get filtered here, has to overcome and then go into the efferent arteriole. With this, we're going to decrease the glomerular capillary pressure, and it will slow down the damage of the filtration membrane. On the other hand, this medication decreases the proteinuria. Why? Because they reduce the pressure in the glomeruli, and in this way, we will decrease the filtration of proteins. Very important protein, and the biggest one in our body is albumin, which is the key protein which we are losing when we have chronic kidney disease. This means if we will reduce the filtration of proteins like albumin, we're going to slow down the progression of chronic kidney disease. And in this way, we're going to decrease formation of fibrosis and inflammation. So we will have preservation of the glomerular filtrative rate over time. Now, here very important things are the side effects. We have one of the most important and famous side effect is the dry cough. Why? Because we're having bradykinin accumulation. Of course, we have to ask ourselves, what is bradykinin? So this is like one molecule which is actually getting broken down by the angiotensin converting enzyme. But since now we're going to block this enzyme, this means this molecule is going to it's going to accumulate within our body, and its accumulation is going to trigger different type of pathways like bronchoconstriction, which can lead to dry cough. Other type of side effects, which is way more severe, is angioedema, as well allergy and hypotension. However, these drugs are contraindicated when we're talking about in patients who have allergy to them, pregnancy or breastfeeding. And please remember, when you're going to have a patient who is having asthma or COPD, and if your patient is already suffering from dry cough, you don't want them to have additional dry cough by the side effects of these medications. So then you can think of giving them different type of medication. And our last group for today is ARBs. The drugs in this case are losartan and valsartan. As you can see, the ending is sartan. Mechanism of actions, they are selectively and they are competing to block the angiotensin 2 receptor. This is actually the receptor where the angiotensin 2 is binding itself. Where can we find actually these receptors? We can find these receptors in the vascular smooth muscle, adrenal cortex, kidneys, heart, and brain. Now, what are the side effects? So the mechanism of action of this drug is going to be exactly the same. Just in this case, we will not allow the angiotensin 2 to bind to its receptor. This means we will have no water reabsorption because we won't have antidiuretic hormone secretion, because angiotensin 2 won't be able to stimulate the pituitary gland. Then we won't have vasoconstriction, which means we can have a slight vasodilation, or we will have decrease in the systemic vascular resistance. And by decrease in the systemic vascular resistance and decrease of the blood volume, we will decrease the blood pressure respectively. Now, what is better in this group of drugs than what is the positive side is that they don't have this side effect of dry cough. So sometimes when a patient is showing us symptoms of a dry cough, after we have given them this group of medication, we can substitute it and give the ARBs, angiotensin 2 receptor blocker receptors. Okay, side effects is hypotension, angioedema, allergy. And when we don't give them, when the patient is showing allergy, then while pregnancy and breastfeeding. So this was my lecture for today. Thank you so much for your attention, and if you have any type of tips, how would you like the future lectures to be, or if you want me to improve something, I'm really happy to hear about it. I hope that through this presentation I have helped you a bit and give you some better picture how we should study pharmacology better. And we see each other in our next lesson. Bye!